I think that Dr. Smith and I would like to, we see a lot of patients together, and we have these conversations on the phone usually, because we both have clinics on Friday morning. And you actually came and spent time in our hematology clinic with Dean Connors. And
time ago.
so we thought that we would just take an approach of having the talk that we have on the phone when we're faced with different patient issues. So we have 4 or 5 different cases, and we thought that it was a small enough group that maybe if you have questions, we don't mind. Just interrupt us as we go. And we're going to go through these cases of kind of fictional patients to highlight different women's health issues and take it from OB and from hematology. So, but feel free to interrupt us.
Yeah, I think that's great. So feel free to jump in.
Okay, so should we figure out how to go forward here? All right, so I have to turn this part of it. All right, so our first case is a 15-year-old female. She's brought into clinic for heavy periods. She started having her period a year ago, and her periods have been very heavy, causing her to actually miss school days and miss activities with friends. She says that she bleeds through 1 pad an hour. She actually felt faint on a few occasions. She really has no energy, and she's missing events with her friends and things because of her fatigue. So I thought maybe we'd start, Dr. Smith telling us you see this patient in clinic, and what worries you, how would you approach this, and what makes you want to send her my way?
Yeah. So I'd like to know a little bit more about her menstrual history. Are her periods coming regularly every month? When we ovulate regularly and have a nice organized menses, it tends to start and stop more predictably. For girls who don't yet have regular ovulation, or similar to perimenopause when women are slowing down with their ovulation, I always think of the uterine lining as getting a little bit more disorganized. So then when you do have the bleeding, it isn't necessarily that nice organized period that's a little bit more predictable that women can often anticipate, a couple days of heavy bleeding and a couple days of lighter bleeding. So if this young woman is still just having, she bled today and then she bled 2 weeks from now and then she bled 3 months from now, it may be that some aspect of her heavy bleeding is just because she's not yet regularly ovulatory. Typically, the first approach is just birth control pills, and birth control pills can be prescribed to girls all through their menstrual lifetime. So that would be our first step of trying to get the bleeding a little bit more regular and also a little bit more manageable. And we'll talk a little bit later about some different approaches to ways that girls and women can take birth control pills.
Right.
And I guess then the next question is, so when do I refer her to hematology? If we've done all the usual things and she just is bleeding through everything, then we need to be concerned that either she can't make it for the 3 weeks that she's taking the hormonal pills until the time of her period, or her periods are still so heavy that she is bleeding through a pad every hour and feeling faint on a few occasions. We'll check her blood count, of course, see if she's anemic yet. Still, it doesn't necessarily mean that she has a bleeding disorder. Some girls are just unlucky in the setting of periods, but that would be the time to start thinking about it. And certainly if she had any family history of bleeding disorder. I guess the other questions, of course, do you bleed at any other times, when you floss, brush your teeth, all that kind of thing.
So let's go on. No? You want it. All right. So just to orient us, just that, women are more likely to be diagnosed because of all these challenges at an earlier age. And even a mild bleeding issue can really impact life, right? As we see here. These, not being with her friends and missing school. So we really need to think about that. And then also, there was a lot of fatigue that we mentioned, and these patients who are having heavy periods could actually now become iron deficient. And so we need to think about ways to replete or keep up with their iron. So when do I suspect? When they come in and they come to us, and now from OB they're sent down to us, and we want to say, well, when should we suspect that they have a platelet disorder? Of course. Dr. Smith has already got some basic labs, so we already know that the platelet count is good. We know that the PTT, the coagulation parameter test that we do, we know those are all normal because usually those are already done for us. But we want to think: is this patient's bleeding out of proportion to their platelet count. So their platelet count is normal, but they're still having a lot of bleeding, and all the other things that we would think about have been ruled out. They have a family history. I can't tell you how many patients come to me and they're told that they had family history of low platelets or they had ITP, and they got treated for ITP and they didn't respond when they were a kid. That always comes, that they were 12 and they were given all these steroids and given IVIG and they had a bone marrow and all these things, and nothing worked. And just they're thinking that it's a numbers problem instead of thinking that it's a function problem for the platelets. And other, like Dr. Smith said, history of undefined bleeding disorders, family history is really important, and this idea of familial ITP. So we would actually ask a lot of questions about the types of bleeding, and really, honestly, I can get a lot of information from just the timing of the bleeding. And so we ask, where are you bleeding from? Are you bleeding from your gums and nose, or are you bleeding into your joints? And that right there tells me about platelets versus coagulation factors. So we ask those questions about the locations of the bleeding. We ask, what does it look like? And I know many of you probably already know, but purpura and petechiae, so the little purple spots that suggest that there's a low platelet count. We ask about surgical and traumatic bleeding. Did you bleed right away, or did you bleed days after the surgery? So that, is another question. Are you able to form that clot and hold that clot? So these are kind of the questions which patients, when I'm asking them, may not understand why, but I'm trying to understand their pattern of the bleeding. We very rarely will see joint bleeding or non-traumatic bleeding in patients with platelet disorders. Personally, I have a lab that studies platelets, and I think one of the coolest things about platelets is that you don't need that many for them to be powerful. So we have patients who have very low platelet counts, but still aren't bleeding in their normal everyday life. And I think that's really cool, and it speaks to the power of the platelet. So, we very rarely will see intracranial bleeds or bleeding into the head or internal bleeding. It's more that something happens and they bleed, right? And so this is kind of what we're looking for on the history. Because of my love of platelets, I thought I would just take a moment and show you a little bit about what I do in my lab and about some of the platelet work that we've done. So we all know, I think that everyone knows here, that platelets are produced by this wonderful cell called the megakaryocyte. It lives in your bone marrow, and it forms these. Do I have a pointer? Ooh, no, we don't. Anyway, it forms these long proplatelet extensions, and then those proplatelet extensions actually form little barbells that's down in 5, and those barbells become platelets. There's a hormone that regulates all of this megakaryocyte development and these stages of all this, and it's called thrombopoietin. But you can take all the thrombopoietin away when the platelets are in that final stage. You can delete it and just get rid of it all, and the megakaryocytes are committed to making platelets. And so there is something else that we don't know yet that's actually responsible for that final stage of platelet production. And, my lab and other labs work on that kind of thing. This is just to show you, again, all those different stages. Some of the cool facts that I think about megakaryocytes is that they produce over 1,000 platelets a day, and that, the lifespan of a platelet is about 10 days. So that's why you always have to stop antiplatelet agents for people who are on them, at least 2 weeks in advance. And if I can make this movie work, I'm not sure that I can. Yes, there's a megakaryocyte making platelets. So that nucleus of the megakaryocyte gets pushed off to the side and actually becomes apoptotic, or it dies on its own. And the entire cytoplasm goes into this cascade of making all those pre-platelets and then eventually platelets. All right, so we've talked a little bit about what we would ask for the history, and then before Dr. Smith takes it away on the OB side, I'd also just like to go through what are the tests and what do we do with the tests. So the second case is a 26-year-old female referred to hematology for a lifelong history of easy bruising, heavy periods, frequent nosebleeds, and prolonged bleeding after wisdom tooth extraction. She wants to know what type of blood test will help her to figure out what her problem is. So what is a typical bleeding workup? So I always go to the microscope, and I'm a bit of a nerd. I like to look at the platelets, and I will study them and stare at them. And I'm looking for a number of different things. And I can tell you that there are a few keys to just looking at the platelets that tells you what the problem is. And it's those most satisfying thing to be able to leave the room, go to the microscope, look at the platelets, say, Walk back in and tell the patient without any other testing what they have. It's old science, but it's fun. Then there's something called platelet aggregation, which I'm going to actually take you through because that's the key to diagnosing patients with platelet disorders. And then some of the other things is we actually want to study and look at those platelets on a special microscope. And I'll show you images from an electron microscope so you can see the inside of the platelet. We use flow, which looks at the outside of the platelet, looks at markers on the outside of the platelet, and that's how Glanzmann is actually diagnosed by flow. And then we have genetic testing, which we can also do. So we'll just go through these slides. So here, these are what we look at under a microscope, and those little purple dots in the middle are platelets, and you can see they're purple, and they have lots of little spots in them. If I look under the microscope and I don't see little spots in them, that means the patient actually has no granules, and they have gray platelet syndrome. So I can tell that just from looking at it. If they have big platelets and they're not really bleeding that much, and then I look at the white cells, which are not in this picture, and I see little inclusion bodies, I start to think that they have cytoplasm problems. So there's a condition called May-Hagelin, which again, just looking under the microscope, I can get pointed in that direction. So you can start your workup just from looking there. Platelet aggregation. Everyone always, even our fellows and some of our attendings who don't spend time thinking about platelets, get really confused about this. And I like to present this in a really simple way, just thinking about light and how light gets transmitted. So what we do is you take blood and we spin it and we collect the top layer, the yellow layer, that's the plasma. And once we have that, I do this all the time. You take it and you just kind of like put it in the test tube and just spin it around, and you actually see a little tornado cloud in your platelets, and you can see that it's cloudy. And so I can actually see that those are the platelets that's making it cloudy. If I took a pinpoint flashlight and I tried to shine it through that tube, not much light goes through the tube because it's cloudy. And when you're doing aggregation, you're measuring just the light that's going through the tube. So if you add something that stimulates the platelets, causes the platelets to aggregate or clump together, they get heavy, they fall to the bottom of the tube. But what happens? That plasma gets clearer and more light can go through. And that's literally all we do while looking at aggregation. Is we have this little machine that does, like an electrode looking at the recording of light going through this test tube. And we activate the platelets to activate different pathways. Okay. And we know based on the results of which things that we use to activate the platelets, we can tell you a little bit more about which type of disorder patients have. So these are different ways to activate the platelet. The whole goal is to get secretion and this shape change, and to get platelets to bind together by a fibrinogen, which is the tubing-3 receptor, which we all know and love in this room. So various things can impact your platelet aggregation. The wrong anticoagulant, a platelet count that's too high, a platelet count that's too low, platelet distribution of these like big platelets, the size of them. If someone ate a meal that's very fatty, their blood is going to be anyway fat, and so that's going to impact it. For whatever reason, platelets like to be more activated early in the morning, and or after exercise, and so that can impact your results as well. And this is literally just what I've just talked to you about. Shine the light through and make an electrode at the top, just watching those platelets clump and fall to the bottom of the test tube. These are the kind of patterns that we look at, and I look at these all day in the clinic. And you just look at which line responds to a different way to activate the platelets, and we all want them to move towards that 100. That's what we're looking for. This is what's going on. If you could actually see the platelets in the test tube, they're resting. They're nice round little circles or ovals. They get activated, and when that happens, they undergo a shape change, and that causes that first wave. Then they release all their goodies. They call in their friends. You have primary aggregation, more secretion, and finally platelet aggregation. So if you could see, which we can, that's what we would see. And this is a normal platelet aggregation, and this is a patient with Glanzmann. So what do I see? So I see that the response to ADP, collagen, epinephrine, and ristocetin are all normal. And I see over here, there's issues, right? So then we have, that's the aggregation. Next, we have electron microscope. That's allowing me to see the cytoplasm, to see the ring of the cytoskeleton. That's that circle that you see going around, all the different types of granules in the platelets. And so when we don't know what a patient has, the aggregation doesn't give us, sometimes we have to send off these studies. Here's a normal platelets with all those little black spots versus a patient who doesn't have as many granules. You can see there's less black spots, right? So we send these studies off and look at them. Flow cytometry is our next line of things that we do. And you can't see it, but 2B3A is, we look for those receptors. And this is basically where lighting up markers on the outside of the cells and running them through a special machine that lets us sort them and count the amount and the function, depending on how we activate them. So there you are. That's all the different kind of receptors that we could look at. And then the really cool thing that's happened in the last few years is actually molecular testing. So we can do next generation sequencing to look at what genes that we know are associated with megakaryocyte and platelet reduction, what genes are abnormal. And we don't even have a disorder for every one of these genes, but we know they're important in the process of making megakaryocytes and making platelets. So we study all of those different genes by doing sequencing. And that sometimes can also give us a good. And so that's been really helpful for us diagnosing patients as well in the last few years, I would say. And now we're going to turn it over to Dr. Smith. So case 3 is a patient who has GT. We know what her diagnosis is now, and she wonders what she can do to control these very heavy menstrual. So I don't know if you want the slide. Sure. One is the advanced.
Oh, the pig. Very large green arrow. Okay, so bleeding disorders in women, and specifically with inherited platelet disorders in women, as Dr. Battinelli said, and as I think everyone in this room knows, women often appear with bleeding disorders earlier than men, other than, I would say, circumcision, which is a time that boys get picked up very, very early. But for girls and women, of course, because of our anatomy, we can get diagnosed through ovulation-associated bleeding, so either hemorrhagic ovarian cysts or just a little bit of bleeding around it, menorrhagia, so heavy menstrual cycles, and then, of course, bleeding during and after pregnancy. This I sort of referred to. So, of course, menorrhagia, the vast majority of women with Glanzmann's will have heavy menstrual bleeding. Hemorrhagic ovarian cysts, it can be a life-threatening situation. Ovarian cysts in general can be difficult to diagnose. Women come in just with acute onset of pain. And I can imagine that if this were an initial presentation for a woman with a bleeding disorder, it would be challenging because ovarian cysts can bleed a lot all the time, whether you have a bleeding disorder or not. And then once you're in there, unlike some surgical bleeding, it's an area that's a little bit more difficult to gain control of because there aren't particular blood vessels, things like that. It's just a bunch of sort of open and damaged tissue, essentially, from the cyst rupturing. And then, so endometriosis, again, associated with menstrual periods. So what I'd like to do is actually we'll skip forward for a second because I just want to refer back to this, and then we'll go back to the previous slides. But referring again to the case of the 15-year-old who came in with the heavy menses, we talked a little bit about birth control pills, and just to give you a little bit more of the kind of OBGYN perspective on birth control pills and a little bit of like birth control pills 101 if you're thinking about for your daughters or nieces or anything else. So this is what a typical pill pack looks like for anyone who hasn't seen one of OCPs. OCPs come in 2 varieties. They come as a combined estrogen and progesterone releasing pill or progesterone-only pills. Progesterone-only pills are much less effective than our combined estrogen and progesterone pills. There are some women, though, who have contraindications to taking estrogen, and some postpartum women that prefer to take the progesterone only. One thing that I'm pretty sure I was actually like a board-certified OBGYN before I learned this is that the progesterone-only pills, they don't have that white line at the bottom of the white pills, the withdrawal pills. The progesterone-only pills is progesterone every single day with just a withdrawal bleed when it happens or if you stop taking the pills. For the estrogen-containing pills, they come in a dizzying variety of doses of estrogen, dose and type of progesterone. Many of the pills have the same amount of estrogen over the whole course of the month. Other pills will have varying levels of progesterone trying to kind of mimic the changes in hormones that happen over a woman or girl's menstrual cycle. Many of the side effects that women experience are from the type of progesterone that's in their birth control pills. So if you or someone you know starts on one and you don't like how it makes you feel, it's not hopeless. There are many different pills with many different side effect profiles. I'm sorry to be neglecting you up a ship. So many pills with different side effect profiles. So you can, try lots looking at the different types of progestin that's in it. In terms of the estrogen, I would say 25 years ago, women were typically taking OCPs with much higher average doses of progesterone. These days, the dose of progesterone has really decreased because we know that it's really estrogen that's associated with blood clots. So not blood clots in your uterus or your blood clotting, but blood clot, deep venous thrombosis, so blood clot in your leg or your lungs. So we typically, for an average person, will start them on a very low dose estrogen pill. So that would be something like 15 micrograms of estrogen. But 30 is readily available. And there are some pills that have 50 micrograms of estrogen. And it's really the estrogen that helps to prevent the bleeding over the course of the menstrual cycle. So there are some people who, if you kind of think about risk benefit, they're at low risk of having a blood clot, they're at low risk of having a stroke, for example, or a heart attack. We might even talk about having them on a significantly higher dose of estrogen over the course of the month. What about these white pills? You don't need them. Just skip them. You can just keep going. You can take the hormonal pills every single day and never get a period in an ideal world. Or for some women, they just can't. The uterine lining builds up too much and they'll have some breakthrough bleeding. So for those women, I usually suggest, well, fine, stop it for just a couple of days, let yourself have that bleeding, and then just start right back up again. It doesn't have to be 7 days. There's no magic to it. So women really can very, very safely play around with it. The combined OCPs, as I said, they're more powerful than the progesterone only in many ways, including in preventing pregnancy. So you can miss a pill here or there without too much effect for most people, whereas the progestin-only pills we usually recommend really try to take it at approximately the same time every day. Even missing a dose or two really will put you at risk of pregnancy. So that's kind of the one-on-one on birth control pills. It's not like there's just one thing called birth control pills. The other option is the IUD. So for many women may have heard their grandmothers, for example, talking about IUDs, and IUDs are bad and stay away from them. And it was the case in the 70s that there were IUDs that were associated with pelvic infections. Those IUDs had higher complication rates. This is a whole new world of IUDs. And I would say as OBGYNs, we often joke on our labor floor and in our clinics that like most of the women working there, whether they're a doctor or a nurse, midwife, they all have an IUD because we love them. They work great. There are a few different types of IUDs, just to be aware. Again, it's not all one thing. So there are some IUDs that don't have any hormones at all. Not a good choice for somebody with a bleeding disorder. So those typically the brand name is the Paragard, and that's also called the copper T. About 30% of women actually have heavier menstrual bleeding when they use the copper IUD. When you're thinking about the progesterone-releasing IUDs, the one that most people are the most familiar with is the Mirena IUD, which is good for 5 to 7 years and probably actually a little bit longer than that. A minimally smaller IUD that also releases a minimally lower amount of progesterone is called the Kyleena. There's also the Liletta. So they're starting to have more and more brands of IUDs out there, but with that lower hormone level, it's also only good for 3 years, probably actually 5, but we encourage women to come in for a switch out after 3 years. So that's the kind of world of IUDs. So a lot of different options out there. I would say for somebody, it is very, very difficult to predict how a woman will do with an IUD placement, especially if they haven't had a child, so their uterus has never been stretched out. But even if they have had a child. So for some people, it's really not, it's a little uncomfortable, it causes a little bit of cramping, not that big a deal. For other people, it is like very, very painful, especially if their cervix has never been manipulated before, they've never been pregnant, so their uterus has never been stretched out. We're very lucky at our institution that our family planning colleagues will take those women, they'll take any woman and place an IUD under anesthesia because we don't have to be suffering with all of this. So the fear of pain or the fear of the placement shouldn't be something that deters you from getting an IUD. Similarly, I would say, there are some women who have a lot of hesitation about like having something inside of them. Am I going to feel it? Is my partner going to feel it? Well, if you feel it past 2 weeks out from the placement, it's probably not in the right spot. I have personal experience with this. It's painful. You can feel it. So in that case, we just pull those strings right out, comes right out. Partners shouldn't be feeling those strings. We trim them. They just go flush with the cervix. We call them strings. They're actually little metal threads, but very easy to just pull it out again, place it again. In terms of risk of bleeding at the time of the placement, hopefully not. Probably better than the alternative of having menses. You might have a little bit of spotting with it, but it wouldn't, in a typical person, it wouldn't cause bleeding to do the IUD placement. So that's a little bit about the world of IUDs. Before we kind of move on from that, actually, does anybody have any questions about IUDs or OCPs?
Yeah.
Yes. Oh, either way.
Yeah, well, it's I have one kind of just my path again.
Hi, how are you?
Hi.
My daughter's not here, but she's the one that should be here. Well, some people might have heard before, she is 17 now, and then the first, episode was strong, the first menses.
Mm-hmm.
So we placed IUD on her when she was 13.
Mm-hmm.
She started having a lot of cramps.
Mm-hmm.
For her, it didn't work. And then her body expelled it 3 times to the point that we said, okay, that's it. So the only thing that at this point, thank goodness, works for her now, they actually moved her to the progesterone pills and the depot shot.
Mm-hmm.
That one is still giving her, please. And she would forget when she got to the estrogen she'll take the white ones.
Mm-hmm.
And then, I took it by mistake.
Mm-hmm.
And then she'll have another bleed. So we move now to depot and the patch.
Mm-hmm.
So the patch, these two have worked for her. I know every GT patient girl is different, but those are the things that, in the future, there's a lot of moms here with new girls, new kids, that they might write it down and say, okay, this is when it comes to their time. Because that was mostly of all the new moms when GT girls is like, what's going to happen when she has her menses?
Right.
It's like, I'm from Brazil. I avoided to go to Brazil because I was afraid of her getting her period.
Yep.
Because those are the questions that we had. So, and that's interesting that you say all the amount of progesterone, her grandma had breast cancer. So you're afraid of how much estrogen.
Yep.
And how does it affect the gynecology that she had? She said, in her case, it wouldn't be that much of an
No, it's so a couple things. Thank you, first of all, for highlighting the patch. I so seldom prescribe it that I didn't put it on the slide, but yes. So there is the patch, which also releases estrogen and progesterone, and there's also a vaginal ring called the Nuva ring. There's some questions about if it has a slightly higher risk of blood clots due to the DVTs due to the type of progesterone. But for young women, their absolute risk of blood clot is very low. As we're thinking about, and sorry, I should also mention, you can also use these together. So I will say a very close friend of mine, her daughter is using both of these things together. She does not have a bleeding disorder. That's just what she needs to be able to control her periods. It's really unfortunate that your daughter lost those 3 IUDs. That's the problem with that small uterus that, hasn't developed yet. But I'm glad that the depot is working for her. So the depot just stands for any kind of shot that it is a depot, basically. It sits around in your system. So it's Depo-Provera. So it's a progesterone shot that lasts for 3 months. It's not favored by a lot of people because of some of the side effects associated with it, like weight gain, for example, but it is a great option, especially if girls are forgetting to take pills and if the side effects are working for her. In terms of the risks of taking estrogen, so it's different, right? So if you're 50 and you smoke and you have a little bit of high blood pressure, your risk of having a heart attack or a stroke or a blood clot is very different than if you're 15 and healthy, right? a 15-year-old's risk of a blood clot or a stroke or a heart attack, those are all the things that are associated with estrogen, are really very, very low. So even if you're slightly increasing them by giving her estrogen, they're not so high that I think it would warrant not taking those medications. I like to contextualize it sometimes in comparison to pregnancy. So most people don't go into pregnancy thinking like, oh my goodness, I'm going to have a heart attack or a stroke or a blood clot. The amount of estrogen that your body sees during pregnancy is far greater than it is while you're taking birth control pills. The difference is, of course, that pregnancy is like 40 weeks long and the birth controls you might be on for many decades. Does that answer your question?
And if I could just add, because of the risk of clots. So, we usually just ask, and I know you ask, right?
Yep.
We just ask questions about family history of clots, and then that can help us a lot too about those decisions about who can have higher levels of estrogen and who may be more at risk for having clotting disorders that could be impacted by having OCPs on board. Yeah. Yes.
Yeah. Yeah. And we'll kind of actually come to that, but just if there's another question about the contraception.
It's a
what? You work some sort of magic. Okay, so this is something that I and Missy as well within the group. Even when somebody new joins our group who they have a very small daughter, right? We're immediately like, you've got to start planning. You've got to start planning. You've got to start planning, especially when you're seeing, periods starting early and earlier, right? And I know things have changed so much just within the past 10 years, but the birth control thing definitely is something that I don't think it's necessarily talked about in extent by gynecologists, right? So I know I was told like maybe 4 different varieties when I first went. And I think that's pretty much the same thing when we have people talking in the community. They're like, oh, well, my gynecologist recommended this, this, or this. There's so many more out there and so many more options. And then there's so many different ways of how these GT patients are trying to handle it. I know that with my sister, my family decided that they just were going to, with her bleeding history, not even chance it, right? So what they ended up doing was she was on for about a year to... Well, I would not. Yeah, she doesn't recommend it. I don't think my mom would recommend it afterwards or anything. But she was on the Depo-Provera shot every month.
Yeah, it's 2 doses every month. So I got it was 2 doses every month for 2 years, and it caused extreme exhaustion. I slept 16 hours a day, had to drop out of school for a little bit and do homeschooling. It was absolutely horrible. I don't recommend it. I just have such bad history with that. Don't
do what she did. But I'm just saying, she did not actually go through her first period until she was after she would have naturally gone through it, right? So that option that they took was to just not even do it. But I do know that the concentrated birth control dosing is something that a lot of people do use to maintain it. Mm-hmm. But then we also have within the community the complete opposite, where it's kind of okay, well, let's see how bad it is once she starts her period. And now this 10-year-old girl, 11-year-old girl has been in the hospital for a month and they cannot get it under control. Mm-hmm. So what would you recommend, a happy medium, not going too extreme one way, but again, not just kind of, oh, let's just wait and see, and then you end up in a life-threatening situation?
I would say I believe that I saw that later on your agenda you have a pediatric gynecologist, and not to kick the can down the road or anything, but I there's a lot to it, and there's family history, right? So if the family has a terrible bleeding history, is given the phenotypes are different, right? The way a disease appears in a different family is going to be different. And I guess if you have a little girl who
if you've already taken her to the emergency room 3 times by the time she's 7 years old because she fell and cut herself and had lots and lots of bleeding in the emergency room, that's probably going to be different than a child who went through all the normal like bumps and scrapes of early childhood and has never had any significant bleeding.
And what about also, if you think about that case, someone who's not so severe, right? And you think, okay, we'll do it low dose once they get their period. And if they need it, we could actually give them a little bit of tranexamic acid.
Yes.
Right? So we could, even though there is this theoretical idea that there's this combined risk of, for clotting, which we've actually never seen. But, right, we have other things beyond this to help us when there is more bleeding than we expected.
Yes.
So, right? So maybe that would be an option for someone who wants to try to have their first period. And then we don't want them in the hospital for a month with them.
Right.
So there may be other things that we could have ready and, send the parents home with to use, maybe. Yeah, I think that's great.
Did you want to say anything?
Yes. No. So I would just so Dr. Smith would tell you that we have all the oral contraceptives and the IUD, and I would say that we have other hemostatic agents that we use even in patients who don't have platelet disorders that have been immensely helpful in controlling bleeding after surgeries and with heavy periods, and patients who are on anticoagulation and have their period and are bleeding the whole month and really coming back into our office, and we can't stop their anticoagulation. So we have other options like tranexamic acid, which is a big pill. It is very big, and so it's hard for people to take, but it works really well. And so I just say that's something that I actually give most of my patients who have a bleeding disorder, so that if they do get into trouble and they're not near a hospital, they can at least start that and then get to the hospital. So that's something that we would consider, I would say. And then we're going to talk a little bit more about this, but the other things that we want to be careful about is we want to use platelet transfusions judiciously in patients. And I'm sure all of you know this, but we want to just be careful because we don't want antibodies to develop, and that'll be part of what our next little topic would be, I think. But, so we want to be careful about that. So judicious use of platelets. So for those reasons, OCPs, IUDs, tranexamic acid, anything else that we can do, local things that we can do are really important at giving options for those kind of expected bleeding problems. And then really being on top of iron, because we don't want our patients to bleed so much that they become iron deficient and then have, reasons for fatigue because of iron deficiency. Yeah.
Well, thank you. Being metabolized by P450 enzymes, I guess, or
Some of them.
Yeah. So is there a chance that there are some are fast metabolizers or slow metabolizers? That's why they react differently?
Probably, especially we see that with different types of anticoagulants. We definitely see that. So sure, it could be part of it.
Would the insurance, for example, allow genetic screening to see if the patient is, I have a personal experience from my own son, and they did this testing for him, and they completely changed the dosages of some medications because he was a fast metabolizer for some, slow for others. So I was wondering if this is the case for some of these medications.
So I can't speak to whether or not insurance to pay for that, but I do know that I do have some patients who come in with a whole entire panel and say, these are the medications based on my genetic profile that I'm going to. So it is possible. I have had patients do that. I don't know if they paid for that.
Now they do pay.
Okay.
Now the insurance pays. I'm just asking how often do you have to, do you need to know this information would be crucial for your decision?
It wouldn't be crucial for mine. I think I would try it and see how they do, especially with tranexamic acid and with oral contraceptives, which are working in different ways. But I guess it really does depend on the medication.
Okay, thank you.
My answer.
Thank you.
Hi there. So my daughter's 3, and she already has an OB GYN assigned to her because, she is hospitalized quite often with pretty major bleeds. So we know that anticipating that'll be a challenge for her. I always joke because when I was pregnant, I didn't want to have a girl because I didn't want to pass on endometriosis because I've had complications. But, I gave her a bleeding disorder instead. So overachiever. But on that note, she's obviously at increased risk for endometriosis just given family history. My mom has it, I have it, etc. Is like her having GT, is that going to convolute anything in terms of diagnosis of endometriosis should she develop it?
Well, the nice thing is that she's going to be, her menstrual cycles are going to be suppressed from a very early age. So that should help with endometriosis as well, I think.
So I know we have a lot of group members that are kind of in between. We have several of us that are, 30s, 40s, and then we have several that are just coming into their period stage. Some of us that have been on it for longer term, it's not often that we have an OBGYN and a hematologist in the same room. So what are some of these side effects that we can have for being on these oral contraceptives long term, as well as like if we need to come off because one, we decide to have a child or because of other reasons, like, just symptoms that you don't want to have and you need to come off. What are some of our options as we get older?
Well, at first I'm going to tell you the positives, which is that quieting your ovaries and your uterus for all those years decreases your risks of uterine cancer and ovarian cancer. So yay, that's a plus, right? Otherwise, from an OBGYN perspective, it's fine to be on OCPs for your life, really. I mean, these are hormones that your body's making anyway, right? Estrogen and progesterone, at least up in, through menopause. So it's different formulations than what your body would make, but it's not harmful to you to keep your ovaries and your uterus quiet.
And from a hematologist point of view, I would say back to what we were talking about before, it's a whole, for the side effects that we worry about, it's really clotting as you age on OCPs. And then it's, again, just a whole overall risk assessment. Is it someone over 35 who's a smoker, obese, has a family history of clotting disorders, has heart disease? So it's an overall risk assessment that helps us decide what the risk of having a thrombosis is. But most women who are not smokers, not obese, and don't have a family history with heart disease usually do. So, yeah.
Sorry. No, you mentioned clotting, and obviously, with GT, that's not a huge issue. But if you are pretty regularly taking clotting factors, how does that affect with the birth control? Because now you're not only taking it over-the-counter medication that could increase that, but you're also putting clotting agents into your body.
So we worry about that, and we usually have a conversation about that. And honestly, I've actually never seen someone clots when we're doing, so we have them on OCPs, and then we have them taking stuff for von Willebrand disease where they don't clot. We worry about it. We read the black box warning, and yet in real life, I've not seen it.
No, I think beyond sort of the population risk, what I was going to say was sort of going back to your comment about, and you were worried about, it's like very classic, right? You were focused on the endometriosis because that was the thing that you were worried about. And you mentioned that you have a family history of blood clots in addition to your child who has the bleeding. That often, when I'm doing preconception consults, like people are really laser focused on the problem that's in front of them. So whether it's their history of endometriosis or the family history of blood clots or something, and it's worthwhile always remembering that although we may have like a primary problem that we're super focused on seeing all the specialists, we also can have everything else that a normal person can kind of have. And so it's always worth remembering, like taking the family history, like maybe it's true and true, like maybe there is an inherited clot disorder, right? In addition to the bleeding disorder in the family that is actually important to sort of know about. Do women get clots sometimes on birth control pills? Like, yeah, but all people have that risk, or taking a long flight or just an unprovoked blood clot. So the risk with GT is probably not significantly larger than for any individual who is doing those things. And the most that you can do is just think about that risk kind of stratification of if your overall health is as good as possible, you're staying active, trying to exercise, keeping your blood pressure under control, all of those things, you'll reduce some of those secondary complications too. I think that answers the question. Oh, yes, sorry. And that reminded me, the other thing I was going to mention, though, along those lines is, if you're somebody, say you're in your 30s and you've been super, super focused on getting the exact right formula for controlling your periods, and then suddenly now you're like 48 and you're having heavier periods again, don't forget that it's not just necessarily perimenopause, but other things that happen too. Fibroids grow over the course of over the course of your lifetime as your hormones change. And so if you're finding that you previously had a regimen that was really successful for you, and now you have a regimen that's not successful for you, it's not necessarily the case that like your birth control pills don't work anymore. It may be that now you have 4 fibroids inside your uterus. And so your gynecologist maybe needs to re-image your uterus and think again about that, or you have a cervical polyp or something like that. So just don't forget about the other things. It's not always going to be the Glanzmanns. Yes.
Just a comment. The gynecologist and the obstetrician gynecologist in the same room at the same time. I think that's one of the things that's really important to ensure that to get optimal care is that you're going to a center where the hematologist and the gynecologist are talking to each other, if not only in the same clinic. So, for example, many of the hemophilia treatment centers around the country have women and girls bleeding disorders clinic that are staffed by hematologists and gynecologists jointly. And you can find a lot of these. There's an organization called the Foundation for Women and Girls with Blood Disorders, and they have a program that specifically fosters the development of these girls and women's clinics. And you can find those clinics around the country through the Foundation for Women and Girls with Blood Disorders. And it's a great resource to be able to look at. But to have your gynecologist and hematologist talk should be the standard in what you expect, should not be special. You really should have that as your go-to person.
That's absolutely. We agree. And, we actually both have clinic on Friday morning and end up sometimes just stopping what we're doing and calling each other.
Oh, yeah.
So we might not physically be in the same clinic, but, we're often talking, and it's right. It is the absolute best way to care for patients.
100%. Not just also sending somebody for a consult and waiting for the note to come back, but just having this conversation back and forth, I think in a way that's very humble also of, I'm like always learning something new when I'm talking to Dr. Banalite. So it's great.
And also then there's no surprises, right? Because
no surprises.
We don't have some plans. When things happen, we already have plans in place from both sides. So
right.
We can.
Right. I think I was just checking the time. I think it's 3:20.
Oh, yes.
I know that you had another talk this morning on pregnancy. We had a couple of things. Unfortunately, neither of us were able to attend, and I apologize that I'm looking at my phone. I'm actually on service this week. But let's talk for a minute about preconception counseling. So I'm a high-risk obstetrician. So as a high-risk obstetrician, I do a lot of preconception consults. And wanted to talk a little bit about, and I apologize if this is all repetitive from what you heard this morning, but the way that I think about people when they come to me for a preconception consult in terms of strategizing for safe care through pregnancy. So in my own mind, I divide pregnancy into 3 time periods. One is I decide I want to get pregnant until I'm about 7 weeks pregnant, and it looks like the baby's developing normally, no miscarriage, no ectopic pregnancy. Then we have the period from about 7 weeks through delivery, and then we have postpartum. So many women, by the time they've come to me, they've talked to their hematologist, they have a sense of kind of what's out there, and they're like, all right, so this is really scary, but is it time for me to stop my birth control pill, take out my IUD, and try for this? So a couple of things. This is sort of going back to the thinking beyond just the one condition that's in front of us. So one thing I wanted to highlight for this group is What is the normal amount of time that it takes to get pregnant? So we typically, for a woman who's under 35, think of 1 year as the amount of time that you try to get pregnant before you get diagnosed with infertility. As women get a little bit older, that time period shortens. And certainly if they've been on like chemotherapeutic medications, then we always worry about what their fertility status is. Now, if we have somebody who has a bleeding disorder, having them come in and say like, okay, just you stop your birth control pills and call me in a year if you haven't gotten pregnant is not an optimal plan. So what I typically suggest in that circumstances is let's get as much information as we can about fertility. So that's both the woman in front of me and also the partner. So we'll send the woman to my fertility colleagues, or if they have an OBGYN who does fertility evaluations, just do some of that. Ask them like, what exact testing is indicated is going to be a little different based on your history. But what kind of testing can we do to see, is my uterus a normal size and shape? Might I have fibroids in my uterus that make it difficult for me to get pregnant? Do I seem to have normal ovarian reserve? Do you have a family history of premature ovarian failure, for example, or was it hard for your family members, your mother, to get pregnant? Does your sister or your mom have a lot of miscarriages? All of those kind of things are going to be important. And that's all information you can get while you're still on the birth control pills, still have the IUD in place. The partner can go get a semen analysis, because lots of infertility comes from the dad department as well, to make sure that everything's looking good from that perspective. Then I encourage these families to make a plan with a fertility doctor. So based on what their history is, how long really are we going to try on your own before we help you to get pregnant, or going straight to IVF, for example? So if you're super healthy, ovarian reserve looks great, everything looks great, then it's reasonable to just go ahead and try. But there are lots of people who my fertility colleagues are like, you know what, let's just go straight to IVF, because I think we can do this better and faster that way. So, you need a good fertility doctor and be really, really thoughtful about it. But a year later is not when to find out that there's a fertility problem or a difference in the shape of your uterus and your anatomy, right? So that's one thing. The other thing is that while you are probably, again, laser focused on bleeding disorders, we also have all the rest of, the world's kind of genetic problems and medical problems to think about. So during pregnancy, we do 2 different types of genetic testing. One type is a testing most people are familiar with. So that's things like testing for Down syndrome. So we can't do that testing until after somebody's pregnant, because those are all issues of the baby. The other type of testing that we do is called carrier screening. And that's testing to see if women carry a condition that could be passed on to the baby. Now, the conditions that we're testing for are typically those, if you pull yourself back to your high school biology class, that are autosomal recessive. So in those cases, in order to have the disorder, you need to have 2 abnormal genes or 2 abnormal chromosomes. So if you carry the disorder on 1 chromosome, your child should be unaffected. But if your partner also carries that genetic disorder, there's about a 25% chance that your baby will have the full disease. So these are things like cystic fibrosis, spinal muscular atrophy, which is an inherited form of weakness that can be fatal, sickle cell disease. And these are all things that we can test for before you get pregnant. So if you come to my office pregnant, I'll say, great, congratulations. Would you like to do this carrier screening? If you come back positive for, say, cystic fibrosis, we'll test your partner, see if your partner also carries cystic fibrosis. And then you have to decide what you want to do. If you want to do any kind of invasive testing to find out if your baby is impacted by the disease or not. So in this wonderful world that we live in right now, all that testing can be done before you even get pregnant. And believe it or not, it seems like crazy to think, but so I do these preconception, I did one just before I came here. I do preconception consults all the time. I offer people carrier screening. I have had several people actually who have been picked up as, for example, carriers of Fragile X, who then go straight to IVF with selection of unaffected embryos and then implantation of an uninfected embryo. And as we get further and further with genetic testing and genetic understanding with Glanzmann and other bleeding disorders, those kind of things will be in the future as well, that if you wanted to select unaffected embryos, that will be in the future. So anytime that we have a known genetic disorder or a family history of some genetic disorder, as long as we know what the abnormal gene is, the companies that we work with can actually create tests to test for that genetic disorder. So it can't just be like, oh, somebody in my family has X. We need the blood from that person often to know what exactly the genetic disorder is, unless it's something common like cystic fibrosis. So this can go from just basic preconception carrier screening to these targeted genetic testing that we work with our IVF embryo lab to do. So something to think about. The other thing to think about for those women who are, in their 30s, for example, and who are thinking like, pregnancy sounds pretty scary. I know that you have some medications and some treatments we can do right now. I kind of want to hedge my bets though, and let's see what the world can bring us in 5 years or in 10 years for that treatment. It has become very routine these days to bank embryos, right? Or to do egg preservation, essentially. So we do this for women who are undergoing chemotherapy, right? If we're worried about what their ovarian reserve will be afterwards. So you can do I don't see a lot of nodding in the room, but I think probably most of you kind of understand. So we stimulate your ovaries, we pull out the eggs. And the other thing that you can do with that, which financially is a large burden, but is feasible, is use a gestational carrier. So you can use your own genetic embryos, but then have a gestational carrier that carries them so you can actually completely avoid the risks of pregnancy to yourself. So things that are out there. So,
and I would add that what you were saying about that, the preconception work of knowing and thinking about other disorders, because when we're faced with, okay, now we're going to stop the oral contraceptive for pregnancy, well, we want to make sure that is there endometriosis? Is everything okay? The fibroids, because we don't want anything else to be leading to that heavy bleed, right? We know that there may be heavy bleeds because now we're coming off of estrogen because we're going to try for pregnancy, but we want to make sure that we've optimized everything else. And so that's why it's really important, this kind of preconception screen, even just because we wouldn't be able to get you off oral contraceptives if we don't know what the full situation is. And then being ready to prepare for that, right? So having transexamic acid, having recombinant 7A, which I know some of you may carry, having those things ready just in case there is an uncontrolled period.
Before we move on, because I don't think we have very much time left since it's 3:30, does anybody have any questions just about the sort of preconception counseling piece?
We don't have to get through our slides.
Yeah, it's fine. Whatever. Because we have some more slides about pregnancy, but we're not sure exactly what you covered this morning either, so we can... I love that you asked that. Yes, we think so. So I would say we've been using it. So yes, we have actually started in kind of the last 4 or 5 months. We have had a couple of people who have either bleeding disorders or just, whether or not you have a bleeding disorder, some women, they have a little bit of separation of the placenta from the wall of the uterus early on. So like placental abruption is what that's called. And for some women, they just bleed and bleed and bleed and bleed and bleed. And the problem is that the bleeding for those people it's not necessarily life-threatening to mom. It's not necessarily life-threatening to baby, but that blood in your uterus is very irritating to your uterus. So then it can cause cramping, preterm labor, premature rupture of membranes. So anything that we can do to try to sort of settle down the bleeding, we think maybe that's going to be helpful in getting to the end goal. The case we had recently of somebody who had a bleeding disorder, was maybe going to have a platelet disorder. We'll see. So she just bled and bled and bled and bled and bled. And we gave her a bunch of TXA over the course of the pregnancy. But yes, so it has been described. I would say that it's not, I sincerely doubt that it's like FDA approved for use in pregnancy, but based on our understanding of the mechanism of action and the impacts, feel that the benefits will outweigh the risks. And I would say we've been giving it pretty freely over the last couple months, but that's not going to be at every institution. That's something that's for us. Probably because we have such a close relationship with our hematologist, so we can be.
I would say that's really key here, right? You have to find a hematologist and OB or any specialist who's willing to explain risks to you and
make sure that it's all there. Everyone understands what's going on, but maybe willing to think outside the box a little bit.
Yeah.
Perfect. Right. Exactly. Or a great mom like
Yeah, that's right.
I have another question.
Yes, please.
How risky is it for egg retrieval in a GT patient? And what is kind of the timeline? I mean, if you're talking about a 35-year-old that's, let's say, coming off of birth control and trying to get either an egg retrieval for pre-hysterectomy or pre-pregnancy, whatever they want to do. What is kind of the timeline, a typical timeline for that?
And do you mean for what age to get it done, or of how long it takes to get it done? I think that's going to be very institution specific. I kind of follow along with the notes whenever I send people straight from their consult with me to their consult with their fertility. And it starts with phone calls with the nurses about their insurance coverage and calls to the insurance about what the level of coverage is and what medications are covered and that kind of thing. So much of the timeline for how long it takes is outside of just straight medical care, but more because it's expensive stuff and figuring out how best to do it. And sometimes people end up going to like a private practice instead because they contract differently with their insurers and everything else. In terms of the risks, I mean, yeah, sure. There's certainly the possibility of causing bleeding. I think the question is always, what are your personal goals and what risks are you willing to take to get there? And what is your own bleeding profile, right, as you're on your way there, I would think. Is that about right? And then I would work closely with the hematologist and, be pre-treating and anything that we can do to think creatively about a safe procedure. It's not intrinsically a very bloody procedure. So, but anytime that you have a procedure, there's a chance of having some bleeding or a complication. So I think that's the part that becomes a little bit tricky. It's not the most dangerous thing you'll have done, but you can never say that there won't be a complication. It's an egg retrieval. So it's like the first step of egg retrieval. Yeah, basically they stimulate your ovaries and then they like suck the eggs out of the little cyst. I mean, it's really cool I don't do it myself, but it's pretty cool stuff. So that would be something, so like Dr. Cannell, who spoke to you earlier about from the hemophilia clinic. So he and I share, she's still pregnant actually, a patient who, she needed to have an amniocentesis, right? Which she wasn't really kind of anticipating. And so we had to create a whole kind of protocol around that to send her, for like pre-infusion and everything else, and then came over the amnio and coordinating between our practices. So the tricky thing with pregnancy is that we're super focused on birth, and that is the time that the highest risk time to have bleeding is at the time of birth. But pregnancy is just unpredictable by its nature. So some women have implantation bleeding. Of course, there's an issue if you have an ectopic pregnancy or a miscarriage, you need to have a DNC. But even with a routine pregnancy, you might have a placenta previa. So the previa is implanted over the cervix, which is on its own associated with some bleeding. There might be a little separation. These are just routine pregnancy problems that cause bleeding and then become more challenging if you have a bleeding disorder, or there's an abnormality on the ultrasound and you'd like to do genetic testing. In the first trimester, that then is a biopsy of the placenta called a chorionic villus sampling, or CVS. And that, the placenta is a very, very vascular organ, and we're putting needles in it and kind of going like this. it wouldn't really be my first choice for somebody with a bleeding disorder, but if they like really wanted to do it, we would work together to find a creative way to pre-treat them to mitigate the risk as much as possible. And amniocentesis is much lower risk, but you're still putting a needle through the muscle of the uterus, and that muscle can then have some bleeding there as well. So it's not zero risk. So there are, forewarned is forearmed, I guess. So we work together to try to come up with strategies, like if-then strategies. If she comes in with this, then what are our first, second, and third options for treatment, knowing that everyone can have regular pregnancy complications in addition to the bleeding that can happen at childbirth.
Yeah, and I think that when we're happy, when we have a patient who comes in and says, I'm pregnant, but for me, I know what keeps me up at night is worrying the what ifs, right?
Yeah.
What if they miscarry? What if they have, and then, oh my gosh, where are they? Are they at a place where they can get the care that they need? And so this is literally what wakes me up in the middle of the night. And so, that's why having these discussions, having this plan in place for tranexamic acid and 7A on hand is really important.
I was thinking as you were talking earlier about how powerful platelets are. It's amazing, right? This group, I think, more than any people that you would bump into on the street is probably familiar with normal platelet counts and things like that. So for a vaginal birth, if your platelets work, you only need 20,000 of them to not bleed at the time of a vaginal birth. So they truly are amazing. Even for a C-section, you only need 50,000 platelets to not have bleeding. So functioning platelets are super, super powerful. My favorite story about that, and I know it is one of my very early patients who actually was exactly that. She had a platelet disorder. She was walking around with a platelet count of 20. And she told, did we share her? Did she have 3 pregnancies?
We did.
Yes.
And her the only reassurance I had was that her mom had her.
Yeah.
And her mom had platelets that were low.
Yeah.
Right? And, did fine.
Yeah. She got a little infection from her last platelet transfusion, but other than that. So, yeah.
I think
are we out of time? We can show you all the rest of the slides we have, but maybe more. 10 minutes. Should we see if there's anything? We jump in if there's anything that seems particularly interesting. So I think we talked about most of these things of that, thinking about the delay to conception, then early pregnancy loss, of course, so bleeding with miscarriage or ectopic pregnancy. So, we also care for a lot of women who have clotting disorders. And so for them, we worry about as soon as that estrogen level comes up of having a blood clot. And so we get them in very early for what we call viability scans. So viability ultrasound, make sure the baby seems to be alive and inside the uterus, because as you may know, 20% of pregnancy ends in early miscarriage. So it's really very, very common. As I say, and I don't say it in jest, that I think there's actually a lot of magic to taking a sperm and an egg and creating a human, right, that's completely differentiated with all these different organs and has the right number of chromosomes and all the different cells. And there's a lot of room for error. And that's why we have all these early miscarriages. So it's very, very normal, but we don't want people to sit around with them and not know. So 6 to 7 weeks, we would have you come in to have a viability scan and make sure everything is chugging along and the baby is in the uterus and not in the tubes. Talked about bleeding complications too, from things like previa childbirth and then postpartum bleeding. And the postpartum bleeding is interesting too. So many people come in, because I saw in a lot of the literature about GT, a lot of talk about PPH, right? So postpartum hemorrhage. For us, though, postpartum hemorrhage comes in a lot of variety. So postpartum hemorrhage is, first of all, super, super common for a gazillion different reasons. You had twins, you had an infection, your labor went on forever, or maybe you have a bleeding disorder, or maybe there's a little bit of placenta left behind, or maybe there's a fibroid in your uterus. These are things that we deal with every single day of the week. And so when we hear from somebody, if, somebody from this room comes in and says, like, well, I haven't had a pregnancy, but my sister did, right? And she had bleeding at the time of childbirth. So what I want to know to understand, to be able to risk stratify, is it somebody who has high likelihood that they had bleeding because of their bleeding disorder? Or is it that they were on labor and delivery for 3 days, they had a fever of 102, the baby was 10 pounds, that kind of thing. So again, I just want you to, when you read about things like PPH, it's not like a one size fits all. There's a lot of information there to better understand the situation. Did you want to talk about this? conversation.
So maybe next slide. So one of the things that we see,
Here you go. Antibodies.
yeah. So one of the things that we worry about is that if we, give a patient a lot of platelet transfusions, this will give an opportunity for the body to make antibodies. And we worry then that when we need to give patients platelets because of a big bleed, that they won't respond. And so, I really try my best to really make sure we're going to use as little platelet transfusions as possible, use tranexamic acid in IVs, use DDAVP if we can, use anything else that we have in our armamentarium before we're going to platelets. And this is precisely the reason, because we don't want these antibodies to develop. And one of the things we worry about in pregnancy is that if mom has antibodies, that, could this impact the baby? And then the baby develop a thrombocytopenia or a low platelet count? And does that then put the baby at risk of having hemorrhage? It's usually in the brain. And so we were actually talking about this before and wondering, we see this for disorders that are not related to Glanzmann's or other platelet disorders. We see this happen for other platelet antibodies that are developed. And we have a strategy for dealing with that. And we were actually just chatting about whether or not that strategy had ever been used in GT. And so we're thinking, maybe that would work. So again, thinking outside the box, not being afraid to try things as long as we know the risks of them. But that is something we do worry about. And
if I could jump in for 1 second along those lines, in terms of the thinking outside the box, it's sort of interesting because, I'll give you an example of a patient that I recently and also for many years have cared for who has sickle cell disease. So her blood count is really the problem for her. And the thing with sickle cell is if we transfuse them with blood, they break down the blood right back down to where they started. So it becomes an issue as well. She has an allergy to blood, which is that she actually has a hyperhemolysis. So she breaks down even more of the blood if we try to give her blood. It's very easy for the blood bank to put allergy in the chart and say, you can't give her blood. But when she's pregnant and bleeding, then we're like, okay, well, that's not a solution that we can use in this circumstance. So let's go to the next level. We need to think creatively about this. What are we going to do when we need to transfuse her? And then we came up with a creative strategy of treating her with steroids, potentially with IVIG to block her own immune response to the blood products. So similarly here, we have to think about when we have the platelet antibodies, the first is so we call it neonatal alloimmune thrombocytopenia, or NATE, is the condition where women have platelet antibodies that cross the placenta and can cause the brain bleeds. And so the antibodies, the way it works is very, very similar. And so the algorithms that you see are, very similar as well with IVIG and prednisone based on the antibody levels. And then the other piece of it is, well, what about for mom? If we say we can't transfuse platelets, but what if we really have to transfuse platelets? Then what do we do? And that's where we have to think creatively.
Yeah, and we also just talked about the risks and benefits of actually doing those platelet aggregation studies before and after and looking for, do they respond? Do we see the patterns correct? And, it is an exposure to platelets, but it is also an opportunity to see if the body does respond. So that's some of the things that are not on the standard way, maybe not so, would not thrill the blood bank.
No.
That maybe we have to think about, right? So,
yeah. NATE. It's if you just Google NATE, NAIT. Yep, NATE, neonatal alloimmune thrombocytopenia. NATE, and that's typically when there is a platelet antigen mismatch between mom and dad, and then the mom creates antibodies to the dad's platelets, and then if the fetus has dad's antibodies, then the mom's antibodies attack the baby's platelets.
And it's not necessarily related to platelet disorders, right? It can happen in people without platelet disorder.
Yep. Yeah. But they can get sensitized in the first pregnancy, and then in subsequent pregnancies, it gets worse and worse.
Yeah.
So, but that's kind of creates a format and a structure in which to think about it. And I guess along these lines that I sort of mentioned earlier to the question about the egg preservation, that I usually recommend to people, like, check in with me every 5 years about if you had some horrible pregnancy outcome and we couldn't explain it and I don't have a treatment for you and I can't guarantee that you're going to have a better outcome, come talk to me in 5 years, because medicine advances really quickly. And you shouldn't assume that just because you got a really good consult from a really smart person 10 years ago, that knowledge is up to date anymore. So just keep asking what's new in the field. I mean, you guys all know because you're on your groups and everything, but
And I have patients, I'm sure you do too, who actually come in to just say, I want to know what's new. And I love that. And, this happens a lot on the thrombosis side. I see a lot of patients with clotting disorders too. And it happens a lot on that side that I will refuse to say to them, they all hear lifelong anticoagulation. I used to be anticoagulated for the rest of my life, and they're 30 coming to this.
And they come see me for their pregnancy, and then I send them to Dr. Battinelli, and I said, can you tell me if she really needs to be on lifelong anticoagulation? 'Cause I'm skeptical.
And we say, at the moment, you need to be so I'll say long duration anticoagulation, but I refuse to say lifelong.
Yeah.
Because, I trained with the world specialist in thrombosis and hemostasis, and that was 15 years ago, and I already do different things than so the world has changed things. And that's
Looks like we're getting the hook over there. Does anybody have any last questions? And I'm sure we have 1 minute left. All right. Thank you so much. Thanks for the great question.
Thanks,